Low back pain is one of the most common musculoskeletal problems, often caused by conditions such as acute lumbosacral strain, weak or unstable ligaments, intervertebral disc issues, or unequal leg length. Contributing factors include depression, smoking, alcohol use, obesity, and stress. Pain related to musculoskeletal causes is usually aggravated by activity, while pain from other conditions often is not. The more areas of pain reported, the greater the level of disability. While this lecture focuses on musculoskeletal causes, it is important to remember that other conditions such as kidney disease, pelvic problems, retroperitoneal tumors, and abdominal aortic aneurysms can also cause back pain. In older adults, back pain is frequently linked to osteoporotic fractures, osteoarthritis of the spine, and spinal stenosis. Inactivity in older patients can worsen other medical conditions, reduce energy levels, and increase overall morbidity. The spinal column is a unique structure made up of rigid vertebrae and flexible intervertebral discs held together by joints, ligaments, and muscles. This design allows for flexibility while protecting the spinal cord. The curves of the spine help absorb shocks from movement, such as running or jumping, while abdominal and thoracic muscles work to minimize stress during lifting. When these supporting muscles weaken from disuse, or when factors such as obesity and poor posture are present, pain often develops. As people age, the intervertebral discs lose their youthful gelatinous character and become dense and irregular. Degeneration of discs is a common cause of back pain. The lower lumbar discs, specifically the levels between lumbar 4 and 5, and lumbar 5 and sacral 1, experience the greatest stress and are most prone to degenerative changes. Disc protrusion or joint changes can place pressure on nerve roots, resulting in pain that radiates along the nerve pathway. This type of pain is often described as radiculopathy, or when involving the sciatic nerve, sciatica. Patients may also report fatigue, gait disturbances, or changes in reflexes, muscle strength, and sensation. Examination often reveals paravertebral muscle spasm, flattening of the normal lumbar curve, and sometimes spinal deformity. The initial evaluation of back pain begins with a focused history and physical examination. The nurse observes gait and posture, evaluates neurologic status, and looks for potential red flags. In some cases, findings point to simple lumbar strain, while in others they may suggest more serious problems such as fracture, cancer, or infection. Patients who are older, who show bruising, or who have been on long-term corticosteroids are at higher risk for spinal fractures after trauma. Nurses must also remain alert to the possibility of elder abuse in cases of unexplained injuries. Another serious condition that can cause back pain is cauda equina syndrome, which occurs when the bundle of nerves at the base of the spinal cord becomes compressed. This results in severe or progressive neurologic deficits, bowel or bladder dysfunction, and saddle anesthesia, which is numbness or tingling in the perineal and inner thigh region. This is a medical emergency requiring immediate referral for surgical decompression or other urgent treatment to prevent permanent damage. Most cases of low back pain resolve within 4 to 6 weeks with simple measures such as analgesics, rest, and avoidance of strain. When nonspecific back pain is identified, imaging is not usually necessary, and reassurance is often helpful for patients. The focus of management is on relieving discomfort, modifying activity, and providing education. Patients with complicating medical conditions, fear of pain, or prolonged symptoms often face higher costs, poorer outcomes, and greater disability. Medication therapy includes non-prescription, non-steroidal anti-inflammatory drugs and short-term muscle relaxants, such as cyclobenzaprine. For chronic pain, tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors like duloxetine, and anticonvulsants, such as gabapentin, may be used. Opioids are generally limited to 1 or 2 weeks for severe acute pain and are avoided in older adults or those with kidney disease or gastrointestinal risks. Corticosteroids and acetaminophen are not effective for acute back pain. For chronic pain, the goal is often to reduce pain intensity by about 1/3 compared to baseline. Non-pharmacologic interventions are highly effective. Heat or cold applications, spinal manipulation, acupuncture, massage, yoga, and physical therapy can all play a role. Lumbar support belts and orthopedic shoe inserts are not recommended as treatment though they may provide some benefit in specific situations such as leg length discrepancy or occupational prevention. Cognitive behavioral therapy, biofeedback, and exercise regimens are especially effective for patients with chronic pain. Patients should avoid twisting, bending, lifting, or reaching that worsens strain on the back. They are encouraged to change positions frequently, and sitting should be limited to 20 to 50 minutes at a time. Bed rest is no longer recommended. Instead, resuming activities of daily living as quickly as possible and engaging in low-stress aerobic exercise like walking is advised. After about 2 weeks, strengthening and conditioning exercises for the back and trunk can be added to prevent recurrence. Diagnostic procedures may be ordered when red flags are present. X-rays can detect fracture, dislocation, infection, or arthritis. Bone scans and blood studies may reveal infection, tumors, or marrow abnormalities. CT scans are useful for identifying soft tissue lesions or disc problems. MRI provides detailed visualization of spinal pathology. Electromyography and nerve conduction studies assess nerve root disorders. Myelograms, though less common, can be used if MRI is contraindicated. Ultrasound can help detect tears in ligaments, muscles, and tendons. Nursing management begins with careful assessment. The nurse asks the patient to describe the pain, its location, duration, and triggers, as well as previous strategies that helped. Work and recreational activities are discussed to identify risks, and the impact of pain on emotional well-being is considered, as stress can contribute to muscle spasm. Referral to mental health professionals may be appropriate when depression or anxiety are present. Physical assessment includes observing posture, gait, and movements, which are often guarded. The spine is examined for curve, symmetry, leg length differences, and paraspinal muscle spasm. Forward and lateral bending are assessed for discomfort or limitations. Neurologic status is checked through reflexes, sensation, and muscle strength. Straight leg raising that produces back or leg pain suggests nerve root involvement. The goals of nursing management include relief of pain, improved mobility, use of proper body mechanics, improved self-esteem, and weight reduction if needed. Nurses caution against prolonged bed rest, as it can lead to deconditioning. A medium to firm mattress is recommended, with pillows or wedges to support comfortable positioning. The prone position is avoided because it increases lordosis. Patients are taught safe methods for moving, such as rolling to one side before rising from bed. Health promotion strategies play an important role in prevention. These include maintaining a healthy weight, reducing stress, wearing low-heeled shoes, walking daily, avoiding jarring activities, stretching, and strengthening muscles. Good body mechanics are essential. Patients are taught to avoid twisting or lifting above the waist, to squat with the back straight when picking objects up, and to lift with the strong leg muscles rather than the back. A wide base of support should be used, with loads kept close to the body. Work modifications such as adjusting chair and desk height, avoiding prolonged standing, and using lumbar support in chairs with arms can all help reduce strain. As patients improve, physical therapy and exercise programs are gradually introduced. These focus on reducing lordosis, improving flexibility, and strengthening trunk muscles. Exercise periods should include stretching and relaxation at the beginning and end. Patients should avoid high-strain activities, such as horseback riding and heavy weightlifting. Posture training is also emphasized. Patients are shown how to stand with the chest up, abdomen tucked, and shoulders relaxed. They are advised to avoid locking the knees or bending forward for prolonged periods. Sitting should be done with knees level with or higher than the hips, feet flat on the floor or supported, and chairs should have firm back support. Safe lifting techniques are reviewed, including squatting with knees bent, tightening abdominal muscles, and keeping objects close to the body. Patients should avoid lifting more than 1/3 of their ideal body weight without assistance. Lifestyle adjustments may also be needed. Carrying children, for example, may need to be limited or modified. Patients are encouraged to resume roles as soon as possible, since prolonged absence from work or family responsibilities may increase the risk of chronic disability. Emotional support, counseling, or antidepressants may help those who struggle to fully return to previous roles. Obesity is a significant factor in low back pain as excess weight strains the back and weakens supporting muscles. Weight reduction through dietary changes and low-impact exercise is strongly recommended. Achieving weight loss not only reduces recurrence of back pain, but also improves the effectiveness of physical therapy and exercise. In summary, low back pain is a common and often self-limited condition. With appropriate assessment, education, activity modification, and preventive strategies, most patients can return to their usual activities and improve their quality of life.